Hi, good evening to everybody. I welcome to all of you for the intervention club. We'll be discussing regarding how to do, tackle with the complex intervention angioplasties. For this symposium, we have two panelists. Dr. Devasis Ghosh from Apollo Multispecialty Hospital. He is the senior consultant intervention cardiologist. And Dr. Manojit Lodha is a senior consultant intervention cardiologist from Ramakrishna Mission Hospital, Calcutta. Presenter Dr. Uday Shankar, Apollo Multispecialty. Dr. Saurabh Chandra from VUI Hospital, Raipur. Dr. Suchitra Majda from Apollo Multispecialty Hospital, Kolkata, and Dr. Raja Nag from Apollo Multispecialty Hospital. So, Dr. Raja Nag, he will be presenting the first case regarding the OCT guidance intervention of the coronary intervention. I invite Dr. Nag to deliver his, his cases and go forward.
Thank you, Dr. Samal. Good evening, everyone. So, without wasting time, I'll straight go to my case. Let me share my screen. So, is my screen visible?
Yeah.
Just a minute. Yeah. Thank you. So, I'll be showing you a challenging STEMI patient who also had multivessel disease. So, this patient is 51 years old, banker by profession, diabetic and hypertensive, non-smoker. He presented with anterolateral MI on 4th of February. His troponins were elevated, creatinine was normal, ejection fraction was around 45% with stable hemodynamics, although systolic BP was around 90 to 100. So this was his angiogram, right radial route with a pipe French catheter. So basically he has a distal RCL lesion with the PD also showing some disease. So this is what his MI was. So his this large diagonal of his is totally occluded, and there is a critical lesion after that in the LAD. So from the angiographic views, we can also make out that there is evidence of calcium even in the angiogram images. So even the LCX had a lesion there. Sorry. So from here onwards, the several issues which were at hand was the patient had a ACS, acute STEMI, with thrombotic occlusion of D1 and critical stenosis of the LAD, multivessel disease, and calcified coronaries. So we did decide to do the culprit vessel first with the planning of doing the diagonal and the LAD through the same right radial route, the 5 to 6 French slender sheet. The guide was a 6 French EBU with 2 wires, one in diagonal and the LAD. And I also decided to go with image guidance to decide whether we would need any special debulking methods for the LAD, as the angiographic images showed significant calcium. So we first opened up the large diagonal. Sorry. So that was not difficult. Now, my OCT catheter wouldn't pass through this LAD. So I knew this was something sinister. So I had to do a P dilatation with a 210 across balloon, but which, like you see from the image, does not open well. And that was after a lot of push and pull on the balloon and the wire. So finally, with a 2.5, we were able to cross this, but still there was waste. Now, after this, we did this 2.5 when I went to high pressures, this ruptured. So now we could not pass any cutting balloon, although I tried to pass a angiosculpt. So took the help of a guidezilla. With that, I was able to arc my IVL balloon of 3 into 12 diameter. And with that, I was able to deliver my first shocks. So I delivered all the shocks there. So after that, this was how it looked like. Even after that, I was not happy with the lesion preparation. So I went ahead with the OPN balloon and went with high pressures of up to 40. So after this, we did the OCT run. The diagonal was having TME3, also the LED. And these are the OCT images. So for shortage of time, I'll run through this OCT and show you the still images. These are the calcium cracks. These are the cracks in the calcium. You can see there was circumferential calcium in the LED, and we achieved considerable gain in the lumen diameter. So then we decided to stent the vessel with a 3 into 34 drug-eluting stent, post-dilated, and then did a OCT run. The OCT run, I will show you the 3D rendering. Yes. So it was well expanded. And there was no evidence of any malposition or underexposition. We did go by the MLD max algorithm, and these are beautiful images of the post IVL and the post stent images where we could achieve significant lumen gain. Just a minute. I'll just. No. Now, what happened that sorry, there was some issue with my net connection. So, are you able to hear me? Are you able to hear me?
Yes, sir. We can hear you.
Raja, we are able to hear you.
Okay, sir. So these are the beautiful post IVL and the post stent images. After which, sorry. So we took the final shot, and the patient was stable, and we kept him in the ICU. And after 1 day, we decided to do the PCI of his LCX and RCA. The RCA again required IVL therapy because there was also significant calcium in that by the OCT images. And he was discharged after 2 days. Hospital stay was uneventful, and he is doing well on follow-up also. So this was the RCA. For the sake of completion, I'm showing this. It was stented with a 4 into 16 drug-eluting stent, and the LCX was stented with a 2.5 into 24. So these were his final images. So there are a few issues in such situations. We know that in all acute MI cases, there will be at least 40 to 50% of patients who will have multivessel disease. And these are the difficult patients, and we need to know like what should be done correctly at that point of time. So we already have this complete trial in hand, which has showed that compared with culprit lesion only, a strategy of non-culprit lesion PCI with the goal of complete revascularization performed early during index hospitalization confers similar benefit on major cardiovascular events. There were benefits of complete revascularization on heart outcomes of cardiovascular death or MI, and which also emerges over the long term of more than 45 days. There were no statistically differences in the safety outcomes also. So these are some of the Kaplan-Meier curves which shows that complete revascularization is better than culprit only revascularization. So what we are afraid of is target lesion failure, and this has also been shown recently that complete revascularization target lesion failure was less common than incomplete revascularization. So the summary and take-home messages are: multivessel disease require careful decision of treatment. If staging, we should make sure that the culprit lesion is treated first in the first session in the ACS and symptomatic patients. We should optimize lesion preparation. Multivessel disease has higher propensity for calcium, and we should also think about proper lesion preparation in the form of angiosculpt, cutting balloon, rota, or IVL. So to conclude, multivessel PCI is appropriate for a large group of patients. Reflexive CABG referral is unwarranted, and careful assessment of patient anatomy treatment plan is essential for optimal results. Thank you. I can't hear anyone.
Please unmute.
Thank you, Dr. Nag.
Yeah, sir. We can hear you.
Excellent presentation, excellent case. I think is performed very nicely without any complications. Only thing that many times we also found multivessel disease during acute MI setting. So what anything GP2B you took in hand during the procedure, or only no other drugs you added to that?
No, the pharmacology was very simple in this patient. We loaded him with ticagrelor, ricosprin, and statin, and we did not require or use any GP2B3 inhibitors. The thrombus burden was not much, and we, as you saw, there was not much difficulty in handling the vessels. After doing balloon or stenting, there was good TIMI3 flow.
Only thing that in the acute MI setting, putting all these things IVL, and again you have to go to the OCT. It takes a little bit time. That's all. Nothing else. Since you are expert, of course, everything available in your center, you can do really well, because you find out it's a very calcified lesion, and it is not opening with multiple dilatation also.
Yeah, so we have faced many a situation where we end up having a situation, a CTO-like situation, even in primary PTCA. So we need to know how to deal with that. And with the present technologies and the hardwares we have in hand, I think no one should be denied the benefit of a primary angioplasty.
Can I come in? This is Dr. Devashish Ghosh.
Yes, sir. Yes, sir, Dr. Devashish.
I think I agree with Raja that in an acute MI setting, since we will be doing more primary PCI, we will get very difficult lesions. It's not that 20% of the lesions will be calcified, and you need to think out of the box. And I think I would have probably tried an OPN first, but crossability of OPN is not as great as A. So, and lesion preparation is very, very important before you put in a stent. So I would say when you are in an acute MI situation, yes, rota is difficult, other things are difficult, but doing out of the box thinking with OPN and see, maybe OPN would have been my better choice as the initial approach. Just try it with an OPN. If it opens up, then obviously the shockwave was not needed. So, but I think this is right, because in
if you allow me 2 minutes, I will explain about the OPN.
Yeah.
So basically, I initially tried with a OPN balloon and even a Wolverine, but I could not cross the lesion with that. Now I had only one option, to keep my IVL balloon pushed at the lesion proximal end and deliver the shock. That is what I did in the first situation, and that actually helped me crack the proximal cap of the lesion. And after that, I was able to take my IVL balloon across the lesion, and that was a risk I took. I know. In fact, if the IVL balloon if I could not have crossed the lesion with the IVL balloon, my job would not have been completed. But then I thought that let us give him a shot. I kept the balloon pushed at the proximal end of the lesion, delivered the shocks, and after that things were easy. This was a very difficult lesion. I'm telling you, even 2.5 balloon was not crossing with ease, even the NC balloons. And I tried angiosculpt and OPN also.
Probably the proximal part is too, very tight. That's why I could not negotiate the balloon. So even if angioscope
And now there are trials which have also shown that even in CTO situations, if you keep a IVL balloon even in the adjacent vessel and deliver the shocks, if the proximal cap is cracked, then you can take it from there.
Yeah.
Thank you.
Okay, so we'll be switching over to second case. It will be the Dr. Suchitra Majumdar. He is from Apollo
Sir,
Multispecialty.
Dr. Suchit Majumdar yet not joined, so we can move to Dr. Sulabh Chandrakar's case.
Okay, so our third presenter, Dr. Sulabh Chandrakar, he is from VI Hospital, Raipur. He will be presenting his case. Dr. Sulabh, I request you to go through the case. Go.
Samal sir, Dr. Sulabh is facing some network issues, so he's logging in once again. So can we move to Dr. Uday Shankar's case?
Yes, Dr. Uday Shankar, he is from Apollo Multispecialty again. I request Dr. Uday to proceed his case.
Audible? Am I audible?
Yeah, Dr. Uday.
Yeah. Good evening, everybody. Firstly, I am very much thankful to About Healthcare for inviting me as a speaker. They have given the topic name is winning over complex lesion. So I am presenting two primary cases, primary PCI. Although both of them are quite unique. First case, the 68 years male, non-diabetic, non-hypertensive. He was in a smoker, had a chest pain for 10 hours. At ECG showing interval AMI. ST elevation was in V2 to V6, along with ST elevation was there in lead 2, 3 AVF. Underlying, he had a bifascicular block and ECG showed wall motion abnormality with ejection fraction around 42%. The right shoot shows RC was non-dominant, normal. The left shoot was taken. There's a critical thrombotic lesion in the just after the proximal part, just after diagonal, and another lesion in the mid and distal relative. This was the dominant left system and a critical lesion in the LPDA. So initially he was treated, was loaded with antiplatelet with ticagrelor. I had an ongoing chest pain, redilated with compliant balloon with 2.5 into 12. After this, they had a good amount of slow flow is there. So I started GP2B intracoronary followed by intravenous, tirofiban started. As given some nitrates along with some nicoran intracoronary. After getting the flow, I started with distally was 2.75 into 48. and measured the proximal with the stent balloon, and proximal part of the LED was stented with 3x38. And after this, the horrible things happen. There is almost no flow, and patient had severe chest pain and hemodynamically was quite unstable. I started on NORADs. This time already some GP2B upfront. I have used already GP2B. Already Tikapur I have used. Already used Decode and nitrates. So he had underlying bivascular block. So I plan to do intracoronary adenosine. So tried with the pre-dilatation balloon. Iatrogenically it was ruptured. I had given 100 microgram initially and followed by another 50 microgram adenosine. And after this, the result was quite okay, and his hemodynamic improved quite a lot. But the problem was after that, the one day after his ST was not quite satisfactory resolute, and he had some amount of chest discomfort. So I again keep this patient to the cath lab 2 days after this primary procedure for LED stent patency, and he was quite okay, at least in angiographically. And initially I was scared to do the post dilatation because of the no flow or slow flow. At the same time, I also thought whether this chest pain was perhaps due to LPD stenosis or not. So I went for stenting, and it was a very soft lesion, easily opened up with a pre-dilatation balloon, and stented with the LPDA with 2.5 into 24 stent. Now to see the anatomy of the LED stenting, whether there is malapposition or any thrombus within the stent, whether that might cause the chest pain. So I did the IVAS. So IVAS actually showed the stent that coming just completely unapposed stent because of the malapposition because of under-deployed stent. So the stent starts. So almost this stent was almost coated within the vessel lumen, almost a hanging. So I was again going for the post dilatation of the LED distally with 2.7 followed by 3 and proximally 3.5 followed by and the ports with the 4. And this was the final IVAS run, which also showed the completely very satisfactory result with stent apposition without any complication. And thereafter the patient was symptom free and he was discharged. Now he is behaving quite well. The second case is 67 years. He is also non-diabetic, non-hypertensive, had a chest pain for short duration, 5 hours. ECG suggestive interval AMI with proximal LED lesion, had a underlying 2RB LHB. Echo LV function was 40%. So when I was planning to take this patient to the cath lab, he had a electrical storm with the form of VT followed by pulseless electrical activity. The ROAC came after giving 2 cycles of CPR. He was started on inotropes in the emergency. In the right shoot, the RC was dominant without any lesion. And after taking the left shoot, the LED was quite thrombotic, total thrombotic occlusion from just after ostium, and a critical thrombotic or any stenotic lesion in the LCX osteoproximal plaque. So I put a temporary pacemaker, discussed with the family member, along with our seniors in our cath lab, whether go for the provisional stenting of LED only, whether go for the elective bifurcation stenting, keeping in mind the electrical and hemodynamic storm in the emergency, or bringing the 4 to the LED and leave this patient for CRBG. But the family members, of course, they are agreed for the whatever best for the patient. They replied, they said, sir. So we had both the LED with run through and L6 with the BMW. Thrombosuction with done with the LED with our eliminate catheter. The big diagonal bunches came, and with the stenosis in the large diagonal, particularly D1. So I put a wire in the diagonal D1. Then pre-dilatation done with 3.5 balloon. So LED2 left main was stented with 3.5 into 38, checked in different views, and deployed at 10 ATM. Flow came and quite okay. Ports was done with 4 into 8 millimeter non-compliant balloon. Then the LCX start was rewired with the filter FC wire, and the previous L6 wire was removed. Distal LED was post dilated with 3.5 into 12 non-compliant balloon, and throughout the LED stent was dilated. Now the LCX ostium and the LED was kissed and opened by 2 millimeter, initially by the 2 millimeter compliant balloon, followed by the kissing of the LED stent and the previous balloon. Now the LED LCX ostium was quite LCX was quite good caliber vessels with supplying a wide area myocardium. I'm thinking of I go for stenting of the LCX as well. So I kept my balloon in the distal LED stent, but I took a 2.75 into 16 millimeter stent for LCX to a left main, keeping that a wide angle. So perhaps it could have been better with if I go for the tap technique. So this stent was deployed at 12 ATM, and this stent balloon and the another balloon which was kept distally in the LED that I used for the kissing. And again, this L6 with the and LED was kissing down with non-compliant with the LCX, and both LED and LCX both are non-compliant balloon. One more with keeping back to the LCX balloon into the inlet main. And the final pot with the same balloon, that is 4 into 12, 4 into 8. And this was the final result with the patent of both LED diagonal and LCX. This was the final result without any jeopardizing a diagonal lesions. Although there is some lesion, but there is no flow obstruction or no slow flow. He is quite behaving well. Lesion follow up. That's what my side. Thank you, everybody. I can hear you, sir. I can hear you. Yeah.
Excellent case, Dr. Uday. I think really congratulate for the second case. It is really excellent. So patient comes in cardiac arrest and revived. I think only thing that IVP would have been, I think, a choice also should have gone to put IVP first so that you could have another support you could have got. But without that also you manage very nicely. And it is at the end you got of course, since you are doing LD is totally occluded and LCX is nearly very critical. So when you are losing the patient, it is better to go for standing both the vessel and see what is happening. You should not leave that, because otherwise, some part of myocardium which is in still ischemic, you leave and do in the second pass, and it is obviously it is better to do in that case completely. I feel that. So the method and everything, whatever is excellent. You did a thrombosexton, very nice flow in the LD, and at the end you open the LCX and put a stent by the collet and all this whatever technique you follow. It is
actually from the opposite one for IBP, but because of financial issues I did not use, and moreover I supported the hemodynamics from patient side, so he tolerated all the procedures throughout the procedure quite well. Yeah, that I think is an excellent case. The patient got survived. That is one thing excellent. And what about, did you use the GP2B and all this patient? Yes, for the second case I used the sterofiban. And the first case I thought it's not very thrombotic, and so I did not use in the first case initially I did not use, but whenever there is slow flow after ballooning I used that. But on the other hand, in the second case from the start I used the GP2B. The first case looks, the normal fluoroscopic view doesn't look like it is stent is mal opposite in the distal part. Yeah. But the IVAS, whatever you did it, or OCT, that would have been better to see that how much opposition and all. But the what will long stent, you put a I think 38 millimeter, again another stent is I think some around 40 or something like that. So it's totally 80% of the LED is totally stented. Yes, so of course the long-term result drug-eluting stent. Let's see what will happen. But it's a good result of what sometimes adenosine gives a good brisk flow to the slow, if it is a slow flow really. So and sometimes you give nitroprusside also. So that is also excellent to talk about the slow flow. Of course, adenosine is the excellent drug to tackle it. Since you have already used the GP2V,
So that
Already.
is the only thing left that adenosine can help you out.
Yeah.
So, can you move to the third case? Dr. Suchit is ready.
Sir, not yet joining in, sir. Sulabh,
Dr.
sir, can you
Sulabh?
share your screen?
Dr. Salab is ready.
Yes, I am ready. I can share my screen.
Okay, Dr. Salab, I request you to go to your case. So if you can present.
So I would directly like to go to my case. My patient was 68 years old male. He was non-diabetic, hypertensive, and reformed smoker. He had complaints of chest pain, severe chest pain 3 months back. Exactly for which he didn't took any medicine or any help. But he came to a different hospital with complaints of angina on exertion. His ejection fraction was 40 to 45%. ECG I'm not having, but it was showing Q waves in the inferior leads. With this background, patient went for an angiogram. And in the caudal view, his left main was normal, distal L6 was 100%, osteoproximal LAD was normal. But after the proximal, after proximal part, osteoproximal part, there was mild plaque. In the cranial view, we can see that the mid part is diffusely diseased, and two large diagonals are coming, which is supplying a significant part of the myocardium, and both the vessels are definitely greater than 2.5 mm. This was the right side. Right side was more or less normal. Plaque was there in the PLV. With this background.
Okay. साथ तो कुछ बोल ही नहीं रहे. ठीक है. Okay.
With the patient was advised actually CABG by this hospital, but patient was not willing for CABG because his brother has died of during CABG, so he was reluctant for going for CABG, and moreover the L6 was also not visible. Target lesions, distal targets were not visible, so I feel that CABG was not a good option, and patient was also not willing for it. So after explaining to the patient, we went for angioplasty. Our plan was to open the first the LCX, then decide about LAD. First, the LCX was tried with the normal workhorse wires on blue, but there was difficulty in crossing, and it was not crossing the lesion. So we took a Fielder XT. After some time, after 5-10 minutes of trying, it went into a branch, and we felt that it was a right track, so we partially withdrew it, and then we partially withdrew it and went further. And after daughtering, we saw that we were in the right track. That we were in the true lumen, and there was no there was no per for dissection kind of thing. So it was a true lumen, but it was a diffusely diseased LCX. So after after pre-dilation with subsequently with the larger balloon and all, we ended up putting two stents, 2.5 into 24 in the distal LCX and 2.75 into 24 in the proximal LCX. After post-dilation and all, the result was good. This was done by right radial route, and then we decided to do the LAD, and the LAD, both the diagonals were very large, so we didn't wanted to lose any of the branches. So we decided to do it. We decided to do double bifurcation, directly stunting the diagonals, and then LAD via step crush technique. First, in the distal part, after this diagonal, after second diagonal, we placed the 3 into 24 mm stunt, and then by this 8-inch sheet, we placed a 2.5 into 16 mm in the diagonal 2, and 2.75 mm into 32 mm in the diagonal 1, and 3.5 into 28 in the proximal part of the LAD. Then we inflated the diagonal D1 and D2 stunt and crushed it with the proximal proximal LAD stunt. And then subsequently, the vessels were recrossed and FKBT were done. First in the first between the below the diagonal and the D2 and the below the diagonal with 3 into 12 and 2.5 into 12 mm PD balloon. And in between the D1 and D2 branch LED, and the D1 we did it with the 3.5 into 12 and 2.75 into 12 mm, and the proximal port was done with the 4 mm balloon. So we ended up placing 6 stent in the patient by double bifurcation technique, but complete revascularization was achieved. So this was his final result. Ideally, I would have loved to do imaging, but unfortunately, my center doesn't have it. So, but overall, it was. Thank you. Thank you, sir.
Samal sir, please unmute yourself.
Excellent presentation, Dr. Solab. I request panelists for their views, Dr. Manojit and Dr. Devashish, for their opinions regarding the case.
Sir is not audible.
Hello, am I audible? Yeah. So whether the D1 ostial, how significant disease was there in D1 ostial lesion? So by D1 ostial, D1 mid segment very severe disease, I understand, but was the D1 ostial was also diseased?
Yes, sir. D1 osteo was a disease, sir.
Can you see the NGO before the?
Yes, sir. I'm going to this.
Yeah. Yeah.
Sir, one minute, sir. Hello. Sir, in this view, we can see the haziness, sir. The D1 ostium, sir. Allocranial, sir.
Okay, yeah. Yeah, no, yeah. I got it.
Looks arise from the disease part itself.
Yeah,
Yeah,
yeah.
yes.
No, it's arising from the disease part, but I wanted to know whether the D1 ostium itself was disease or not.
Yes, sir. It was disease.
Yeah, okay. And how? What was your catheter size?
8 French I took, sir.
8 French. Okay.
Yes, sir.
Yeah.
Sir, USG guided puncture I took because I was not having any closure devices, so I called radiologist. And patient was more or less a reformed smoker, and I mean he was not willing for CABG. And,
That's excellently done. Thank you.
Thank you.
Dr. Devashish, any opinion? Dr. Solab, I think.
Sir, Dr. Sujit sir is joining in 5 minutes. We just wait for 5 minutes. He's facing some network issues.
Okay.
Just 5
So
minutes.
meantime, I just want to Dr. Solab, he has a reference smoker, and he has a diagonal 1 block, diagonal 2 block, LED block, and LCA block, And of course, I think, do you think that this complex angioplasty will give him a long-term good result, or we can go for
Sir,
standing?
sir,
As you
this
told
idea
that
is
he refused for CVG, no doubt of that. First
this,
of all, he
this
refused
idea is
CVG, that is one thing. But
Yes,
these
sir.
smoker patients, they never leave the smoking. So,
Yes, sir, but since 6 months I've been following him. He's coming regularly.
doing well.
Yes,
Yeah.
hopefully, till now he's fine,
Yes.
sir. But let's see. Long-term result, we all know, sir. It won't be,
Yes, because
won't be good. But angina was severe, sir. There was no option. He was already taking medicine, and CABG, sir, he was just not willing for CABG.
yeah, of course, if you're not willing that, we have to do something for relieving
Yes,
the. So no doubt of that.
Yes,
So
he
it
was-
is excellent.
COPD
So, result was excellent.
Thank
So obviously, you should relieve from the symptoms. So. Dr. Debasis, can you give some opinion from this case? The LED D1, D2, and LED he has done in a single setting in double D1,
So I'll
D2,
go
and
deeper.
LED. Triple,
Yeah,
you can set one setting.
yeah. So there was a call from the hospital where I had to advise. So I'll be there for the next cases. Thank you. I'm sorry for that.
Rahul, can you move to the Suchitra Majumdar's case? He's just talking about the
Sir.
physiology.
Yeah, sir. Dr. Suchit sir is joining in 5 minutes.
Okay.
So we'll just wait for 5 minutes.
No problem. So meantime, can I request Dr. Monjit Lodha sir to tell something about the last speaker to Shalom, who is Dr. Uday Shankar, who has presented two cases. One is slow flow and found to have a mala post stent, and then later he post dilated the stent. Second thing is a acute MI. He did a left main bifurcation in the technique and saved somebody's life. Can
Sir, in the second case of Dr. Uday Shankar, I think during TAP, just my opinion is that circ stent was a bit too much in the left main. So I would probably like to put circ stent a bit less in the left main, because in TAP technique you just have to put 1 or 2 struts in the left main. You don't have to put too much of the stent in the left main. Otherwise, the long-term results are not that good.
the culotte technique, I think the
No, he has
majority
not done culotte, sir. He has done modified TAP.
yeah.
So
I actually done. I tried to do a tap technique, but somehow the stent start is more in the left
So it
vein.
becomes a culotte now.
Perhaps it's a type of modified tap or modified culotte. In between
Yes.
tap and culotte, you can say that.
But no, you
Sir,
cannot
but
say.
my target was to do a tap because it's a quite a wide angle. So definitely, and the diameter was mismatch was there between LED and LCX. So it's not a culotte.
Yeah, it is not a culotte because you have put both the balloons and dilated simultaneously. So it is not a culotte anyway.
Definitely.
So, and in first case,
This is the part. Yeah, I tried to.
where I the left circle. That's what I am saying. If the circle stent is a bit too much in the left main, you put a bit less.
Sure.
And in the first case, when you put the first stent, distal stent, before that, how was the flow in the LED?
After the first stent in the distally.
Yes.
After the first stent, that slide probably is not here.
Yeah.
It's not too good, not too bad. Rather, I say not too bad. But after deploying the proximal stent, the flow was quite bad. So I checked for proximal edge dissection, but it's not there.
Okay, so actually what happens that if after putting one stent or even after ballooning, if you are not getting good flow, then I would suggest first establish good flow before putting a stent.
Sure.
Many of the persons, what they do is that they put the stent in the hope that the flow will be good and there will be no flow. That is
Sure.
not a good idea in angioplasty. So in angioplasty, I always suggest to first have the good flow established, see the distal target vessel well, and then put a stent in the distal vein.
Or
And
if flow is not coming, better to put him on GP2P overnight and take this
overnight
patient.
GP2P, yes,
And that
or
could be an
otherwise you can
option.
give.
But still, after the proximal distal stent, and flow was not bad.
Okay. And second thing, if you don't use the balloon perforation, you can also use microcatheters or even the
Thrombosuction catheter.
catheter.
Because this was the case of primary PCI. This thrombus burden was not initially not to be seen too high, so I did not use the thrombosuction catheter. So if I use the thrombosuction catheter, then obviously I have to use this thrombosuction to use this adenosine. But perhaps I thought I was not using the thermosuction, so I thought that balloon initially during my DM days I used to.
Good idea.
No, that way you can save some money to the patient.
Yeah, not. Yeah.
Thrombosuction, obviously, definitely, microcatheter and all these things.
Yeah. The other thing I'll just quickly come in that the problem is if you have not have a layer of thrombus around the artery which you're not very aware of.
Sir, this was my primary PCI lesion. This was the lesion.
Yeah.
So I thought it's not a very much thrombotic lesion initially, but that came out to be a very no flow situation with horrible hemodynamics.
That is.
And the patient came slightly late at 10 to 12 hours.
Yeah.
But it looks.
I think basically I agree what Uday has done, and basically that would have been a strategy. Unless you go in, actually, most of the cases in primary PCI, you do not appreciate the problems you are winning.
Yeah.
It's only when you go away that you start appreciating the problem. I think that is important. But
after
layered thrombus is layered thrombus is a problem. Layered thrombus is a problem. You undersize the stent and your chance of no reflow. And I absolutely agree with Uday that if you're not getting a good flow, never stent that up, please.
Sure. Thank you, sir.
So Dr. Sujit has joined.
So next, I think presenter Dr. Suchin Majumdar. He is from Apollo Multispeciality Hospital, Kolkata. He will be presenting regarding the importance of physiology in coronary intervention. I request Dr. Sujit to proceed for his presentation.
Yeah. Am I audible?
Yes.
Yes.
So I think I will just do one or two slides, then I will go to the case. So I think my slides are seen.
No, it is not started.
It's coming.
Yes.
Now it's coming. Anything?
Your slides are visible.
Go to the present mode.
Only 2 slides.
Only 2 slides. Then there is the images of the presentation. So I have not put in the slide that images. I don't know it will play or not. Not sure. Slow, very much slow.
Shuchit, my suggestion is when you share your entire screen and then put on the PowerPoint. Share your entire screen. When you unshare and share, that's it. Good.
Okay. So I'll just go to the case. Nothing is there. So just I will show you. So this is a case of a 47-year-old gentleman who presented with an acute inferior valve MI with a pain starting around 4 hours back from the time of presentation. The ECG looked like a classical inferior valve STEMI. There was no ejection disturbances. the initial first year was echinacea with a EF of 45%. There was no MR, no dissection, no other problems. All positional organs were equally passive. Pulses were passive. 120 by 70, pulse rate was around 56 or 58. So after discussion with the relatives, we have taken the patient for a primary angioplasty. I will go to the this thing. I will go to the images of the primary. So I'll just share once more. Share screen. Okay. So, so is it visible? My images?
It is visible.
Okay. So I will just, but that is the last image. I have to get to the first image. 1 second. Stop share. So go to the first image. So the left system I am showing first. Sorry, share screen. Is it visible? No. Not yet, no?
No, no.
Very slow. I don't know. This images anyway. So I will just. I think the left system needs to be showed. Not opening at all. Slowly opening. So should I go to the description?
Your screen is not visible, Suchit.
I know. Nothing is visible, no?
No. You share your screen.
I shared my screen, but this thing is not visible. The videos.
Sir, first share your screen, sir.
I can share. Oh, okay. First share my screen. Okay. So share screen. Okay, I have done it. Now my screen is visible.
No, sir.
Not visible.
First click on share screen option. Yes, yes.
And now it is okay. Suchit, it is working. Just wait.
Okay.
Yeah.
But the problem is that these things are not opening. I don't know why. Because maybe big images. It's very slow. That's the main problem. The DVI loops are opening very slowly. Unless it opens, so I cannot show that thing. So basically, the right system, there was an occlusion from the mid RCA. So we had opened it up. That way it is fine. The left system had some borderline lesions in the LAD and LCX. It's not coming actually. Some execution failed or something. Yeah. So what to do? Some of these things are not playing. Anything? Becoming very slow. When I was not using the Zoom, it was playing very well. But now, after opening the Zoom, no, it is not playing. Maybe because of memory issues or something. No, it is not playing in that way.
Please stop the share screen.
Stop the share screen. Okay, I have done it.
First click on share screen option. Then you can see share sound and optimize the video clip option. Just that.
Yeah, well. Optimized for video clip. Okay.
Yes, optimized for video clip and share sound option.
Then
just click on that, then share your screen, then click the share button. Yes.
So then I will try to do it again. Maybe because of that only it was not coming. But without doing it was coming very well. Then also it is not coming. Not coming. This can play, no? This side, right side. Is it visible in the right side? Hello. Now is it visible?
Yes.
The small thing it is visible. I don't know. So this is fine, I think, no? Can you see this right side?
Yes.
So I'm making it a big slightly. Yeah.
Yes, it is. Okay. Make it right.
So this was the LED basically. Can you see?
Yes.
So we thought it's a borderline, not very significant. These were all the systolic frame. What we are seeing as more significant. When we got the diastolic frame, it was not so significant. So it was looking like a borderline lesion, but not so borderline as to. So after 4 days of 3-4 days of primary angioplasty, we decided to do an FFR for the LED lesion and also the LCX lesion. I will show you the LCX lesion. So this was the LCX lesion. Is it visible? Yeah, I think so. So this was the LCX lesion. So finally, after this was just I will show you the right angioplasty which was done. So this was the final result. I will show you. 1 second. Okay. So this was the result on the right side. There was a lesion in the PDA, but that we did not do anything in that. So we decided for a FFR of the LAB and circumflex. So I'm going to the FFR data. Is it visible now? Hello?
Yes.
Okay, great. So this was the initial part. Then FFR was done on adenosine infusion for 3 minutes. And after that, the LED showed a FFR value of 0.91. And it was looking as non-significant. And on the LCX, the FFR value was 0.97 in spite of looking like there should be significant. So even after stabilization of the adenosine level, we went for FFR there and it was 0.97. So we did not do anything to those vessels and left and discharged the patient. That's all.
Suchit, this is Dr. Devashish Ghosh.
Yeah, I can
Hello,
hear
can
you.
So, Sujit, how after the acute MI presentation, when did you do the FFR? I was just
I think it was around 4 days post primary.
I think that is an issue because you have to take it that the data are showing that if you do an FFR, even in the non-target vessel very early, before the myocardium has recovered, you might get a little erroneous result. And I think if you look at the, even if you say if you were to if you believe in that it was if it was a proper culprit, non-culprit vessel which was significant, you could almost give it almost up to a month. That is the CV culprit trials which have shown that between discharge to 1 month is more or less the same. And I prefer before the patient stabilizes not to do an FFR too early after an acute MI because you do get the distal myocardial bed perfusion is often not recovered enough, though it's the non-culprit lesions. But still, I think it is better to probably delay it a little bit more, maybe 2 or 3 weeks, and bring the patient in and then reassess the vessel. That would be my impression.
After 4 weeks, this L6 lesion might come, FFR might come positive.
Yeah, absolutely agree. It will be there's a lot of false negative results after an acute MI.
Yeah, that is one of the consideration because it may be if that is supplying a part of the this myocardium which is damaged. So that part of the myocardium is now damaged. So the relative demand of the myocardium reduces. So that may give this thing a false negative result. But we thought that it's not a culprit vessel. Even for LAD also, it was not a culprit vessel at all. So LCX, what he said, Dr. Uday, may be true, but I think there was no collateralization and all these things. So I thought that maybe doing it will be helpful.
Because you had to do a second procedure, Shuchi. So even if you delayed it by 2 to 3 weeks, I think that that patient might not have been in much trouble. The lesions were not that acute that it's going to blow up the next day.
Those were not acute at all. We could have delayed. Yes, I agree.
Sir, any other questions from any other panelist on the same case? Or Dr. Uday sir or Sulabh sir, Raja sir, any other questions?
I think there's nothing more.
Samal sir, you can conclude the session if no more questions are there because all presentations were done.
Okay. So thank you to all the presenters. They have presented very nicely. I think a lot of things we learned in acute MI, even also you can do the primary bipercussion stenting. So he has very nicely done Dr. Dasankar. I think even the cardiogenic shock revived and he did a bipercussion setting with excellent result. And IVOS and OCT, both presentation by Dr. Rajan, who has done a OCT, which is also gives stent opposition, excellent how to know that your stent is good opposition, how the calcium and how IVL has helped in putting the stents. I thank Dr. Manojit Lodha and Dr. Devashish for their good panelists for their opinion and giving us very precious time and guiding us in their thoughts. And I thank all the presenter also sparing their time and providing excellent cases demonstration for their things. So I hope we have enjoyed all that this cases. I thank and our company for providing the platform for sharing your clinical and thoughts. So I thank you to all. I hope we enjoyed everything. Thank you to all. Good night.
Good night.
Thank you.
Thank you. Thank you.
Bye.
Yeah.